Hello, my name is Dr. Appel from Ado Psychology Center, where we specialize in treating anxiety, depression, and OCD. Welcome to our video seminar series. Hope you enjoy this video. So this video is going to be on obsessive compulsive disorder, also known as OCD, but it's a very basic primer video. I'm also going to be putting out other videos on OCD topics that are going to relate to specific OCD subtypes, treatments for OCD, challenges that come up within OCD, but this is specifically for the basic first introduction to obsessive compulsive disorder. So the goals for today are pretty straightforward, just to gain familiarity with OCD and to learn a little bit about treatment. There are some misconceptions when it comes to OCD. So have you ever heard someone say, he's so OCD about everything? Or I know I'm being so OCD about this. Or stop being so OCD about this. This is how people talk about OCD in general society sometimes, but it really refers more to people who may be a bit of a perfectionist or very orderly or organized or clean or time conscious, and assuming it's just someone's personality trait and they're happy with how they are, that's not describing what OCD actually is. What OCD really is a disorder that causes tremendous suffering. People often wish that the symptoms would just end or go away. And there's also suicidality within this disorder, with a 44% lifetime prevalence of suicidal thoughts, which means at some point in their lives are thinking about suicide in some way, and 14% lifetime prevalence of suicide attempts, which means 14% of people with OCD at some point in their lives attempted suicide. So as you can tell, real OCD is very different from the way we often speak about OCD in society. So what is real OCD? So here we're going to talk briefly about the DSM-5 criteria for OCD. The DSM is just a big book with all the psychological disorders, and it describes the criteria you must meet in order to get the diagnosis. So first, criterion A is a presence of obsessions or compulsions, and usually there are both. So what are these? Obsessions are recurrent thoughts, urges, or images that are intrusive and cause significant distress. So in a very basic example of OCD, perhaps we'll take contamination OCD, where someone is maybe very afraid of germs or afraid of getting sick, or just feels very disgusted from touching public surfaces, for example, such as a public doorknob or sitting down on a train or a subway. And so when they are in these situations, they may start having a lot of thoughts like, I'm going to get sick, it's so dirty, it's disgusting. And they can't get rid of these thoughts until they engage in a compulsion, which is the behavior or a thought process that one purposefully engages in to relieve that distress that was caused by the obsession. And on the next slide, I'll talk more about other OCD subtypes as well, and examples of images as obsessions, in addition to just thoughts. And then criterion B is that the OCD symptoms take more than 1 hour per day or cause clinically significant distress or functional impairment, which just means that it causes a lot of distress, or it really impairs their functioning. They can't focus on what they're doing. They have trouble, at work, at school, with friends, with family, and it's interfering in their lives. So some common subtypes of OCD include contamination OCD, like I just mentioned, or maybe symmetry OCD, where someone needs things to be in a certain order. So it's not that someone enjoys being orderly, but rather if it's not in a certain order in a certain way, they feel this tremendous distress that could only be resolved through ordering it, and oftentimes for hours. Or sometimes it's combined with what's called magical thinking, where someone says, if this picture frame is not perfect, then whoever this picture frame is of might get harmed somehow, some way in the general environment. There's no actual connection between their obsession and real life, but that's why it's called magical thinking. Harm obsessions, where someone, is afraid that they may be the cause of their house burning down if they don't keep checking the stove. And then obsessions without visible compulsions, also known as like pure O subtype or purely obsessional, which is where someone is engaging in obsessions and compulsions. It's not just obsession, but it's all in the person's mind. So, for example, it may be like, having a thought that maybe they've harmed someone, and then needing to like retrace the events in their mind until they can confirm with themselves, like, no, they're good. Or they need to count up to a certain number in their mind or say a certain prayer in their mind to kind of resolve some obsession that came up. There are also other subtypes that are maybe less spoken of, but often just as common, which are considered more taboo subtypes. And I'm putting out a video just on taboo subtypes. If you're interested in this topic, check out that video as well. But just for illustration purposes on this slide here, pedophilia OCD is where someone is constantly worried and concerned that maybe they are a pedophile. There's no evidence for it. They're not actually attracted to children. And as one psychologist once said, they would rather, if they were to put someone with pedophilia OCD in a room with their 4-year-old child, they'll be more concerned about, the patient with OCD than their own child, because there's no actual risk here. The person is not interested in that stuff at all. It's just a doubt or like a what if I was, or if I did something terrible like that. OCD is called a doubting disease for a reason, because a lot of OCD revolves around the questions of what if or maybe, and it's never fully resolved. Violent or more aggressive OCD sub-themes, again, it's not actual violence or actual aggression, but maybe obsessions of what if I were to stab someone, or what if I punched my neighbor in the face. And so those are some examples of a more what's considered like aggressive subtype of OCD. And then there's a just right feeling, where it's not so much about the thought or the obsessions in that way. It's more about a feeling. Like I need to turn the handle of my door a certain number of times until it feels just right. So oftentimes there's a just right feeling associated with OCD as well. So let's talk about the OCD cycle, kind of how OCD keeps itself alive and what are the mechanisms of action over here. And so when someone has OCD, they often, get triggered from something in their environment. So in case of contamination, maybe they touch a doorknob, and now that's the trigger. And now they have these obsessions of my hands are dirty, I'm going to get sick, I'm going to get other people sick perhaps. And that causes an increase in distress. Now, distress could be anxiety, could be fear, could be worry, could also just be a feeling of disgust. But there's some increased level of distress. And ever since we're children, right, whenever we're not feeling well, we try doing something about it. And so they engage in compulsions, which are behaviors to decrease that distress. It might be as simple as washing their hands. And, fortunately or unfortunately, it actually does provide relief many times in the moment, temporarily. But in the long term, it's not a solution, because obsessions keep coming back. And sometimes the compulsion that worked yesterday doesn't work anymore until it becomes more elaborate. And now also they may be more sensitive towards new, triggers or newer obsessions. And so compulsions is a temporary solution, but often it can exacerbate the OCD and at least not actually be a long-term solution. Let's discuss some underlying thinking patterns in OCD. So the first one is an intolerance for uncertainty. This is probably one of the most common ones we find in OCD, where just the mere possibility of something may be true is enough for someone with OCD to experience tremendous distress and feel like they need to engage in a compulsion. So for example, let's say we'll take the same example as before. Someone touches a doorknob and they're afraid they might get sick now. And they tell their friend, and their friend's like, what are the chances? Like, we're all touching those doorknobs. We're not all like using hand sanitizer afterwards. Really? You really think so? And the person with OCD might respond by saying, well, how do you know for sure? What do you answer that, right? We don't really know for sure, but we're human beings. We live in a life where we have to learn to tolerate uncertainty and just move on with our day. But someone with OCD can tolerate uncertainty. Or let's take the pedophilia OCD example, right? Where again, someone is not attracted to children in any kind of way. They're just afraid, what if I am a pedophile and I don't even know it? And so if you told them, well, what's your proof that you are? And they say, well, I have no proof, but how do you know for sure? Can you prove it? Can you prove that I'm not? You can't really prove a negative, right? That's another issue with this underlying thinking pattern. You can't prove that you're not something, because everything is possible. So that's a very common one in OCD. Another one is overimportance of thought. So just having the thought of maybe punching my neighbor is already intolerable to me. Like, I'm giving it a lot of importance. Another example of overimportance of thoughts, referred to as thought action fusion, is where someone with OCD says, well, if I keep having this thought I'm going to punch my neighbor, I might actually come to punch my neighbor. And again, this isn't the case. These people with OCD generally are the least likely to engage in any of these behaviors, and that's where they're like overly concerned, where the rest of us are like, all right, if it happens, it happens sometimes, right? But that's another common one in a common underlying thinking pattern in OCD. Another one is overestimation of threat. So even if there's a small level of threat, right? Like, yeah, maybe there is a chance you'll get sick from the doorknob. We view it as like a 2%, but in their mind, it's like, oh my God, I'm probably going to be getting sick. So they're overestimating how threatening a situation actually is. Another one is inflated sense of responsibility. So feeling overly responsible for things that are really not your responsibility. So for example, if let's say you are walking in the street and you see a twig or a branch on the floor and you're in a good mood and you want to, protect society, you'll take a moment, you'll bend down, you'll kick it to the side. And but if you're in a rush or if you're in a bad mood or whatever it might be, you might just like jump over it or like walk around it and move on with your day. But someone with OCD will then start thinking, well, wait a second. If someone ends up falling there, I am responsible. Now, I'm not the one that put the branch there. I was in a rush. 1,000 people walked there before me and didn't move it. It was hard to move. It was heavy to move, whatever the issue was, right? And yet I feel responsible. So that's what inflated sense of responsibility is with regards to OCD. We often find a lot of perfectionism and rigidity. Not every perfectionist has OCD, right? Probably most of them do not have OCD. We'll talk about perfectionism and OCPD, obsessive compulsive personality disorder, in another video, which is not OCD. And if you're interested in that, go check that out. But from our perspective here, within OCD also there tends to often be perfectionism, rigidity, inflexibility, and hypersensitive morality, which refers to being like very sensitive towards ethics and moral behavior. So for example, um, similar to before, if let's say I have the thought of what if I stab someone, I may then say to myself, oh my God, what kind of person has that thought? I'm a bad person for having that thought. Whereas in reality, we all have random intrusive thoughts throughout the day, sometimes, and we just like shrug our shoulders and move on. But someone with OCD would say, like, no, I'm a immoral person for having that thought. And I put here healthy aggression in parentheses because it's important for us to recognize that a healthy sense of a healthy sense of aggression is important, right? We get our needs met that way many times, as long as it's healthy and you don't act on all your thoughts. So having, feeling really stressed and like cursing at your neighbor in your mind, right, doesn't make you a bad person. It just makes you human. And so that's something that people with OCD often struggle with is hypersensitive morality. Let's talk briefly about some OCD statistics. So lifetime prevalence is 2 to 3%. So, over one's lifetime, about 2 to 3% of the population has OCD. Mean age of onset is 19 and a half years old. Onset after age 35 is unusual, although I have had a number of patients who began experiencing OCD only later in life. Sometimes you could trace it back to earlier in life with it just being gone unnoticed, but I've had some examples where it really only came up later in life. There's some talk about maybe being related to trauma as well, but even without trauma, OCD can definitely appear later in someone's life. Males, although it's unusual, males have earlier age of onset than females. In fact, 25% of males have onset before age 10. So of the males with OCD, a quarter of them actually began having full-blown, OCD, meeting the full criteria for obsessive compulsive disorder as young children. And most people with OCD also have other disorders. It's called comorbidity, where you have at least two disorders at the same time, such as anxiety, depression, or other disorders. So people with OCD often are not only struggling with OCD, but rather there are other disorders they're dealing with as well. So let's talk about level of insight. When it comes to OCD, there are different, people have different levels of insight into their disorder. So someone with good or fair insight recognizes that their OCD is OCD. And their obsessions and their thoughts, it's all OCD, right? In the moment of the trigger, it's still hard for them to recognize it as such, right? And they feel like they need to engage in compulsions. But if you're speaking with them, they say, oh, yeah, I know I have OCD. I always have like these types of thoughts. I know it's ridiculous. I just can't stop it, right? That's good or fair insight. Poor insight is where someone, doesn't really think so much they have OCD. They're still open to hearing how maybe they have OCD, but really they feel like, no, I don't think I have OCD, and these are real concerns and real issues I need to deal with. In fact, other people maybe should have similar concerns to me. Absent insight or delusional beliefs is where someone, can't be convinced, is not open to any other, possibility and does not believe they have OCD at all. And as you can imagine, it's easier to engage in treatment with someone who has good or fair insight than someone who feels like they don't even have OCD. That being said, it's not hopeless or helpless, because someone who, even if they don't recognize it as OCD, if they say like, I can't live my life, I'm tortured from my life is impaired, I'm experiencing these high levels of distress, you might be able to then, help them coming in from that angle, not really arguing about whether it's OCD or not, but what can we do to make your life more functional? But overall, it's definitely easier to treat when someone has good or fair insight. Now, that being said, as I mentioned just a moment ago, even if someone has good or fair insight, in the moment of the trigger, they may not have. But this is referring to outside of the triggered moment, do they know that generally they have OCD and these are their themes, etc. Let's discuss some treatment for OCD on a very basic level again, and I will be putting in more videos and more nuanced, videos on OCD treatment and what that looks like. But for starters, the gold standard psychotherapeutic treatment for OCD is called exposure and response or ritual prevention, ERP, which is considered a CBT therapy, cognitive behavioral therapy, but specifically for OCD. And in this therapy, it involves both exposures and response prevention. Usually response prevention comes first, and then you also start adding exposures. So what is response prevention and what are exposures? So response prevention is pretty much what it sounds like. It's preventing the response, refraining from engaging in the compulsive response. Okay, so for example, someone's triggered by touching a doorknob and they really want to wash their hands, and part of the treatment is don't wash your hands in those moments. Okay, and the goal with that is to break the OCD cycle that we discussed earlier. So if you remember, someone's triggered by a doorknob, they have obsessions about becoming sick and their hands being dirty or having germs. It increases the stress. Normally, they engage in a compulsion at this point and they use hand sanitizer, for example, right? And again, we're talking about OCD examples, not where it's recommended to use hand sanitizer, but when it's not recommended, or if someone's doing it all day long, right? And so in this therapy, response prevention would say when you are naturally triggered in your environment and you're experiencing obsessions and it's causing you levels of distress, don't engage in the compulsion. Now, what happens if you don't engage in the compulsion? Your anxiety might get worse for a bit, right? Because you're not taking care of it. But over time, your anxiety tends to dissipate on its own. And also you learn that you can tolerate anxiety and still live your life. When you recognize that, that also helps for the anxiety to eventually dissipate on its own. Oftentimes people come to treatment and say, well, I know this is my issue, but you just told me not to do it. And that's a very valid argument. But in therapy, we try giving other skills to help them along with this response prevention. But the core part of this treatment, of this part of the treatment, is ultimately to stop engaging in the compulsions. Okay. Now, the exposure piece of it, which I'll talk more about on the next slide with specific examples. But for now, instead of only being triggered naturally in your environment, right? Exposure is to purposely trigger yourself in the environment. So even if you weren't really planning on going out today much, go out, touch a doorknob, and come back home, right? So purposely do it. And the way I explain it to clients often is that so imagine you're like, drawing a piece of art and there is this annoying kid that keeps coming by with like water balloons and spraying you and messes up your art, right? So every time you chase them, you yell at them, right? You're engaging in that kind of compulsion, we can call it for our example here. And cycle keeps repeating itself every day, same story. One day you say that, you know what? I'm going to ignore this kid and I'm not going to engage in my compulsion. I'm not going to chase after them. I'm not going to redo it. I'm just going to completely ignore them, right? And over time, they'll probably stop bothering you. But what if you took it one step further? You actually yourself filled up a big bucket of water. And before the kid could even come with his water balloon, you pour the whole bucket of water all over your art project. When the kid comes, they feel like so demoralized, like there's nothing left for them to do here. And they're gone for good, right? And so with exposures too, you're communicating to your brain that this is so irrelevant and so you don't care about that you're willing to confront it on your own as exposures, that you then start becoming less and less triggered in your real life. So yes, it's short-term pain for long-term gain. It's hard to pour that big bucket of water, but the more you do it, the more you get the positive consequences and the more free you start feeling and you get your life back, it tends to become worth it. So in terms of specific exposures here, we have different examples of OCD subtypes that we mentioned before. And so for someone with contamination OCD, it might just be touching a doorknob. With someone with more like aggressive OCD or violent OCD with thoughts that maybe I'm going to stab someone, they'll walk around with like a knife in their briefcase, right? Of course, you want it to be safe. You don't want to do anything illegal, but ultimately you want to expose yourself to your core fear. And if your core fear is that you're going to stab someone, you want to do that as an exposure. And over time, you start forgetting the knife's even in your bag. But you have to, short-term pain for long-term gain again. Harm OCD with like the stove, it might be something like, having someone in your house use the stove and then you don't get to check it before you leave the house, right? So, something related to that. And then pedophilia OCD might be like walking past playgrounds, not looking away when, if there are kids there, if you have your own kids or nieces or nephews, playing with them, hanging out with them, whatever most people would do probably. But for you, you've always been avoiding it, right? And OCD, there's a lot of avoidance of triggers, but here we're purposely confronting these triggers. And over time, they become less of a trigger. So ERP, or exposure and response prevention, is not the only therapeutic approach. It is the one with like a lot of evidence behind it and tends to work really well when people can engage with that therapy. But there are other therapies that are gaining more steam lately, such as inference-based cognitive behavioral therapy, which is more of a cognitive approach, a little bit less behavioral, and can be more tolerable for patients who feel like ERP is just not their thing. And it could also be combined with ERP in ways that make the ERP easier to engage in and also might target areas that ERP maybe doesn't target as well. And so very short, right? This is a whole treatment I'm talking about on one slide, so let's recognize that. And also, if you're interested more about this, I do plan on putting out more videos on ICBT, on ERP as well, in more detail, and also contrasting these two treatments and seeing in what ways are they different and what ways are they similar, and how do you combine both, for the, I guess, the ultimate treatment response. But in inference-based cognitive behavioral therapy, it's all about the idea that, the whole OCD issue begins when the person starts doubting. Because once, right, there's some kind of trigger in the environment, and then the person starts doubting. And once they start doubting, right, like, what if I'm a pedophile? What if I'm going to stab someone? What if, I'm going to get sick? Then there are the consequences of the doubt, right? Then I'm going to die. I'm going to be put in jail. My family's going to shun me. I'm going to be a terrible person. That thought causes a lot of anxiety and discomfort. They engage in the compulsions. So this whole chain begins with the obsessional doubt. So if there's a way for us to help people not have that initial doubt, we're kind of stopping the chain early on, and now they don't have to deal with all the consequences of OCD. Right, the idea here is that the intrusive doubts start causing inferential confusion. We start making inferences and we're confused about that, right? So someone without OCD might touch a doorknob. They're not really doubting, am I going to get sick or I'm not going to get sick? And then they say, okay, I'm probably not going to get sick, so I'll go on my day, but maybe I'll get sick, right? Usually they touch a doorknob and they're not experiencing any doubt whatsoever. So if we can help someone with OCD recognize, like, you just touched a doorknob, there's nothing in your environment telling you a danger. It's just false alarms going off in your mind. So is there any actual real doubt here? The answer is no. Then you can stop the OCD process really early on, and really early on in the game. So the goal here is to get to functional certainty. Now, functional certainty is contrasted with absolute certainty, right? Or statistical certainty, because we can never be fully certain, right? In fact, are you certain right now that your roof or your ceiling is not going to collapse on you, right? Can you prove it, right? You can't be certain, right? There is a chance that it will collapse in the next second. But you're not debating each moment whether you should run out of your room and save yourself, because functionally you are certain that your roof, that your ceiling is not going to collapse, right? And so some with OCD, we want to help them also become functionally certain and be okay with that. Remember, we spoke about how intolerance of uncertainty is one of the core underlying thinking patterns within OCD. The goal of this treatment is to get people to a place of functional certainty so they don't even have to doubt and recognize like what's real uncertainty and what's just OCD uncertainty, which is really functional certainty. So again, I know it may be a bit complex, but we will speak about this in a lot more detail in a video that we'll be putting out on specifically ICBT, inference-based cognitive behavioral therapy. But it could be a great treatment alternative to ERP. So just to summarize, OCD comes in many colors or flavors, but the fundamentals are the same. There are obsessions, compulsions, and we spoke about how they relate to each other. In terms of treatment, what's considered the gold standard treatment for OCD is ERP, exposure and response prevention, but there are definitely other treatments available that seem promising and might be more palatable for some individuals who find ERP challenging, and also can maybe provide benefits in addition to ERP if you were to combine it with ERP. And as I mentioned, I'll do other more more nuanced videos on ERP and ICBT and how they differ and how they're similar and how to combine them, but just be aware of the different treatment options that there are out there for OCD. Hope you enjoyed this video seminar. To see a full list of our current videos as well as upcoming videos that we'll be posting soon, visit us at adopsychologycenter.com and sign up to be notified when we post new videos. Bye for now.